Good morning to all our dear participants, and welcome to the Kuwait Telehealth Technology Summit 2022 on scaling delivery of high-quality digital healthcare and value-based care, organized by Trek event in partnership with our strategic sponsor Philips, gold sponsors Advanced Care, and One Source Solutions International. The Kuwait Telehealth Technology Summit is an access to how healthcare providers can empower, strengthen, and overhaul the digital health transformation in the great state of Kuwait. Without question, it has been determined that during the pandemic, telehealth, telemedicine, and telemonitoring have enhanced the quality of healthcare services provided and made them cost effective regardless of the place, setting, or the facilities. I am Roger, and we have Bridget, and we will be your host for today's session. The Kuwait Telehealth Technology Summit 2022 is a platform that trusts the rising initiatives made by the great state of Kuwait towards the execution of state of the art healthcare aid to all, asserting established international standards and national policies with guidelines. The summit will shed optimistic light on the roles of evolving digital health technologies and the future of how healthcare can be delivered. The summit will bring leaders, governments, companies of the health ecosystem from both the private and public entities, including ministries, private institutions, digital experts, and researchers to build and transform the landscape of healthcare. A few pointers to make the most of the session. If any of you have questions, please use the Q&A section where all questions will be answered. If for any reason you get logged out during the session, please follow the same procedure to log back in or refresh your page. All our partners and speakers would love to answer any questions you may have. Kindly set up a meeting or drop a message to them directly, and they will also be available for questions in the lounge area. And don't forget to visit the booths to explore all that our partners can do for you. So, without further ado, let's get this Kuwait Telehealthcare Technology Summit 2022 started with a keynote presentation by our chief guest, Dr. Abdul Badi Abou-Samra, Chief Quality Officer and Deputy Chief Medical Officer, Hamad Medical Corporation. The topic is chronic disease management in telemedicine. Dr. Abou-Samra worked at several international academic institutions, which include Lyon University in France, the National Institute of Health in Maryland, Harvard Medical School, and the Massachusetts General Hospital, and the Wayne State University Medical School of Medicine for 5 years, where he was a professor of medicine, professor of psychology, psychology, professor of molecular genetics, chief of the endocrine division, director of the chronicology fellowship program, and director of the T32 endocrine research training program. Dr. Abou-Samra has received multiple recognitions for scientific contributions and led research continuously funded by the National Institute of Health between 1986 until 2014. He is known for his molecular and clinical research on G protein coupled receptors, insulin action, and nutritionally generated genes. Dr. Abou-Samra published over 217 original papers in peer-reviewed journals and contributed to 5 USA patents, where he also served as a member of the NIH Endocrine Study section and member of the editorial board for several international journals. Professor Abou-Samra joined HMC in 2013 as Chairman of Medicine, where he was then promoted in 2020 to the position of Chief Quality Officer and Deputy of the Chief Medical Officer at Hamad Medical Corporation. He continues to be the Director of the Qatar Metabolic Institute and co-chair for the Qatar National Diabetes Committee. Chief Quality Officer and Deputy Chief Medical Officer, Hamad Medical Corporation on Chronic Disease Management in Telemedicine. Let us all welcome Dr. Abou-Samra, and the stage is all yours, Dr. Samara. Over to you.
Thank you very much for inviting me. I'll be sharing my slides here. So I'll be covering the telemedicine concept for chronic disease, which are also known as non-communicable disease. So we either call them CDs or NCDs. The objectives is that I'll be discussing the burden of chronic disease, the management of chronic disease during COVID-19 epidemic, and telemedicine for chronic disease management during normal life and going forward. In terms of burden of chronic disease, so this is a slide from the from CDC USA, and what you are looking here is a survey of people based on age. And what you see here, for instance, this is blue is the young one, the orange is the one from 45 to 64, and then the gray is the one with the most gray hair above 65. And so what we see here, those who have no chronic illness, of course, mostly among the young and the least among the elderly. And as in those who have only one chronic illness, that constitutes about 20% to 30% from all age group. Those who have two or more chronic illness, you see the elderly, almost two-thirds have at least two chronic illness or more. And if you only count those who have one chronic illness or more, then almost 88% of people above the age of 65 has at least one chronic disease. And again, from the same CDC said, chronic disease are the leading causes of illness, disability, and death in the United States. They are also the leading drivers of, let's say, the nation's 4.1 trillion annual healthcare cost. And on the right side here, I put some data here from Qatar, and these data are published on the website of the Qatar Biobank, and it's showing analysis of 15,000 subjects who volunteered as participants in the Qatar Biobank cohort. And what you will see here is that high cholesterol is found almost in 29% of cases, high blood pressure in 16%, and go on the bottom, diabetes in 17.3%, arthritis in 7.8%, thyroid disease 10%, asthma 9%. Essentially what I'm telling you, that people who participate in the Qatar Biobank cohort who think they are normal, healthy, they have found to have some chronic illnesses in that range, which in the 30% range, although most of these people are young. Now, this is again from the US data. It's showing that what are the most common chronic illnesses found in the elderly above 65. And you see here high blood pressure, high cholesterol, arthritis, heart disease, diabetes and obesity, chronic kidney disease, heart failure, depression, Alzheimer, dementia, chronic obstructive pulmonary lung disease, and osteoporosis. I add that. And if you want to compare it to the most common chronic illness in children, again, several diseases are in common, but there are something unique to children, such as type 1 diabetes, and such as developmental disabilities, ADHD, cerebral palsy, autism spectrum disorder, etc. Now, if you look about premature mortality due to non-communicable disease, I mean chronic disease, and that WHO report 2020, and what you see here, countries labeled with red, that more than 30%, and in the Middle East here area between Egypt and Gulf area, ranging between 20 to 25%, or in Egypt, almost 25 to 30%. Now, if you focus on that area and look a little bit in depth, you'll find areas such as Kuwait and Qatar, where there is an excellent health system providing care to all nationals. So although they have high level of chronic disease, but the likelihood of dying from them is very little, like 10 to 15% or less than 10%. But we have not to forget that although people do not die from the chronic disease, they die from the heart attacks and from the stroke. And chronic disease such as obesity and diabetes can be considered the causes of death. Now, is telemedicine useful? And in fact, the COVID-19 epidemic taught us that telemedicine was very, very useful. Here in Qatar, we actually took a proactive approach to identify subjects who are at high risk of disease, of diabetes here, and brought them into management using phone, let's say, a consultation. Is a kind of telemedicine, but only by phone. And so here identify almost 15 or 16,000 subjects who either have very high risk in terms of their diabetes or average, and distribute them between primary care and endocrinologists. And these patients were called proactively to manage their disease. At the same time, our regular clinic, which include patients who have appointment with us, they all converted to appointment by phone. And in fact, analysis of these data has shown that management by phone after the lockdown or before the lockdown were the same. So essentially, telemedicine was efficient at time of crisis to manage diabetes in this case. So what did we learn? Telehealth saved patients from potential exposure to COVID-19, and we actually did also population health management, and that by targeting high-risk patients selected from electronic medical record and supported by telehealth as a care model. Individual health management also that was possible. Those who have their own appointment, they were managed by telehealth. Other benefits, of course, cost, access, convenience, and saving time for patients. Disadvantages, of course, there were some, but can be tolerated at time of epidemic. Patient and healthcare provider identities were not assured, meaning when the provider called the patient, sometime the patient mother or brother or sister pick up the phone and they want to get the advice to their other significant other, if you like, and that's may play a negative role because the identity is not, we don't know who are we calling. And same time, the other side doesn't know who is the physician who is calling them. And so, but this is being mitigated by now, including video assisted consultation in all telehealth encounters. Physical findings also may be missed and vital sign may not be accurate, and that may cause potential harm. Physician time is not saved. In fact, when we analyzed the time for physician, it was about the same, if not a little bit more, because it takes time to set up that consultation. Patient-provider relationship is weakened, and there is a missing benefit of multidisciplinary team approach for disease management, particularly relevant in diabetes, where you want to integrate dietitian, educator, physician advice to the patient. Now the question, is there evidence that telemedicine can support chronic disease management in daily normal life? Is that mean, is there a study showing yes, there's benefit? And can telemedicine approach be integrated in the clinical pathway of chronic disease management in daily normal life? So I just told you, at time of crisis such as COVID-19, definitely is useful. But when there's no crisis, is it useful? In fact, here the CDC, Center for Disease Control and Prevention, their task force recommended telemedicine for a variety of disease, and there is a review showing evidence that cardiovascular disease management, there's evidence in which there's improvement in medication adherence, management for high blood pressure. Also, there's evidence improvement in self-management. Also, there's another study which analyzed chronic vascular disease, diabetes, HIV, and asthma. And in this study, also they found there's improvement in dietary outcome, by particularly diet quality and healthy intake. And there's another study which also reviewed other criteria, and they found improvement in blood pressure control. So, but however, management of chronic disease is a complex. There's the aspect of prevention, and prevention is very important. This is again data from CDC. If we invest $1 in healthy diet, we would save $11 or $12. So, return on investment. If we spend $1 in preventing alcohol, and so almost $8 in saving in health, and so on. Tobacco and physical activity, cardiovascular disease, and other vaccination. So prevention is very important. Education for the patient is very important. Lifestyle modifications such as physical activity, healthy diet, smoking, alcohol and drugs prevention, sleeping habit, addressing that, coaching and psychological support, medication compliance, therapeutic target, which can be clinical, such as level of blood pressure, weight, can be functional, such as arthritis for knee or ankle, where the patient is able to walk, stand up, etc. Laboratory values such as hemoglobin A1C or cholesterol level. And these issues are issues in chronic disease. A question is, can we address all these issues in telehealth? And just remind you of the most common chronic disease, there many of them can be managed and some may perhaps cannot. For instance, subjects with developmental disability, ADHD, cerebral palsy, autism, etc. Although these are chronic disease, but may not be amenable to telehealth management. So what would be the role of telemedicine in chronic disease management? We already said at time of necessity, such as COVID-19 experience or crisis, there's benefit. Also, there's benefit reported in area where there's a large and fast space and distance from centers in which face-to-face clinic is not possible. And this from Australia, they have excellent system of telehealth to address remote areas, to address urgent patient concern, and this is in supporting such as urgent clinic. The question is telemedicine in normal life, not because of necessity, it's just for convenience or to save money, or because it is equal or better than face-to-face medicine? Is there evidence for that? As clearly, educating and influencing patient behavior may be most effective in face-to-face encounter between patient and healthcare professional in facilities where walls talk to patient. So we say when patients walk, let's say in a metabolic unit, they found all the instruction on the wall and drawing and so on, which influence the behavior of the patient, may not be amenable in telehealth. Chronic disease, however, require quarterly visit to manage side effects. So almost every chronic disease will need to see the patient not once a year, but at least perhaps quarterly. And this is important to manage side effects, reinforce compliance, monitor therapeutic target, which can be addressed by telemedicine. Perhaps at least one yearly visit should be face-to-face and the other visit telemedicine. That's a suggestion I provide, and we are thinking in implementing this in Qatar, such as if I have to see the patient 4 times per year for diabetes, I will make one of them face-to-face in which I do comprehensive assessment and physical exam, and the other follow-up is focused on the therapeutic target, on side effects, or any issues the patient may have to address. And of course, the door is open for innovation in telemedicine to support management of different chronic disease for the different medical subspecialty. So we discussed that there's evidence established from literature review for hypertension, diabetes, heart failure, coronary artery disease, dyslipidemia, asthma, and obesity. As I mentioned, the question is there evidence of benefit for other chronic disease? Yes, this yet to be established. Is the outcome lower, equal, or better than face-to-face visit? It's really not known. We know there's benefit, but is the benefit better? There's no way to compare unless we do clinical trial. And healthcare provider may not be equal when dealing with telemedicine. They may need to be educated and trained how to be effective in telemedicine as much as they are effective in face-to-face. And research is needed to address all these 3 issues. This is my last slide, and thank you very much for listening.
Thank you, Dr. Abou-Samra, for the wonderful insights and valuable words. It's always an honor and a privilege to have your gracious presence with us. I hope you enjoy the rest of the day and the summit. Thank you.
Thank you.